Auzubillahi minash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Assalamu alaikum. This is Maham Kiran, roll number B197035. The topic I'm going to represent is Irritable Bowel Syndrome or IBS. So, what is IBS? Introduction. Irritable bowel syndrome or IBS is characterized by recurrent abdominal pain in association with abnormal defecation in the absence of a structural abnormality of the gut. Types of IBS. IBS can be subdivided into three types: IBS-D, IBS-C, and IBS mixed. IBS-D. This type causes abdominal discomfort and diarrhea. IBS-C. This type is characterized by abdominal discomfort and constipation. IBS mixed. This type of IBS causes constipation as well as loose stools followed by abdominal discomforts. Epidemiology. About 10 to 15% of the population are affected at some time, but only 10% of these consult their doctors because of symptoms. Nevertheless, IBS is the most common cause of gastrointestinal referral and accounts for frequent absenteeism from work and impaired quality of life. Young women are affected 2 to 3 times more than men. Etiology. IBS can develop after a severe bout of diarrhea caused by bacteria or a virus. This is called gastroenteritis. IBS might also be associated with a surplus of bacteria in the intestines, bacterial overgrowth. Diagnosis. Diagnosis of IBS can be done by flexible sigmoidoscopy. This test examines the lower part of the colon or sigmoid with a flexible tube sigmoidoscope. Computerized tomography or CT scan produces cross-sectional images of the internal organs. Colonoscopy. In some cases, doctor may perform this diagnostic test in which a small flexible tube is used to examine the entire length of the colon. Pathophysiology. IBS pathophysiology is not clear, however, certain theories have been proposed, but the exact cause of the IBS is still uncertain. It could be due to genetics, post infections. About 10% of IBS cases are triggered by an acute gastroenteritis infection. Number 3 is brain gut axis, that is, alteration in communication between enteric nervous system and CNS. Management. The management of IBS is based on non-pharmacological as well as pharmacological management. The non-pharmacological management consists of dietary modification. Number 1, avoid food that triggers symptoms, such as gas-forming food like lentils, legumes, and beans. Number 2, low FODMAP diet. Low FODMAP diet means fermentable oligo di monosaccharide and polyols may help to improve short-term digestive symptoms in adults with IBS. Number 3 is fiber supplementation. Fiber supplementation may improve symptoms of constipation and diarrhea. Pharmacological management. Patients with intractable symptoms sometimes benefit from several months of therapy with a tricyclic antidepressant such as amitriptyline or imipramine, 10 to 25 mg orally at night. Or they can also use antipsychotics, laxatives, and opioid agonists. Case study. Sarah Smith is a 34-year-old woman who presents to her personal care provider with the chief complaint of a 4-month history of hard pad-like stools and difficulty when passing stools. She states that she constantly feels bloated and has taken to wearing loose-fitting clothing because she cannot tolerate anything tight around her abdomen. She states that she was diagnosed with spastic colon in college and thinks that she remembers hearing the physician talking about IBS as a diagnosis. She has been able to tolerate the minimal symptoms until about 6 months ago when she began to notice some bloating and a decrease in the number of bowel movements per week. She attributes the worsening symptoms to increased stress at work. Prior to 6 months ago, she states that she averaged about 5 stools a week. She estimates that she has had 1 or 2 bowel movements a week for the past month. She complains of straining to pass her stools and states that she has to get up 30 minutes earlier in the morning to allow for an attempt to pass the stool. She also states that the abdominal pain is not limited to when she passes a stool. She complains of abdominal pain and bloating almost continuously throughout the day for the past 2 months. Although her symptoms are somewhat alleviated by passing a good stool, she also states that the symptoms are worse when she has midterms or finals or when she needs to complete a major college writing assignment. She thought about trying Fibercon but didn't know if it would help her symptoms since both psyllium and Fibercon are laxatives. She switched to sorbitol solution, but she says it tastes too sweet and doesn't seem to help. Soap notes. Subjective, chief complaints abdominal pain and discomfort with constipation, age 34-year-old, gender female, past medical history, seasonal allergies, tension headaches, and anxiety. Objective, lactulose hydrogen bread test that is negative, serum pregnancy test negative, further test abdominal CT scan, colonoscopy, and GI endoscopy. Assessment, irritable bowel syndrome associated with abdominal discomfort, bloating, and constipation. Plan, pharmacological approaches. For the management of abdominal pain, guidelines recommend the use of tricyclic antidepressant for patients with severe or continuous abdominal pain. Antidepressant drug amitriptyline is given in the dose of 10 to 25 mg at bedtime, which is quite effective in relieving the abdominal pain in the patients with IBS. For the management of constipation, higher fish diet, isfagol or psyllium, lactulose, and prucalopride will be recommended. Non-pharmacological approaches, food enriched in fiber, increased water intake, and regular physical exercise. Jazakallah.